of teaching to do, and I'm not going to stop the stream till I'm done with the entire thing. So first of all, there is a few problems in this. The thing is, growth and development is genuinely very poorly mentioned. There is no neonatology, and so I need to do this, and I need to do a pediatric neonate from Marrow. And I need to do those four topics. Unfortunately, for some reason they are not given here properly. Leaving them, I think everything else is pretty okay. So here's the thing, I have done with GIT. It was okay. I need to do the area hemat, RS, CVS, GIT, endocrine and CNS, and including neuromuscular disorders and malignancy. It will take around 4 hours, and it's 1:39. I'll sleep around 5-ish, or maybe I won't sleep today. Maybe I'll just study till 9. Okay, but either way, I'm going to finish Hemat. Maybe I'll do fast. Everything I'll do fast. Hemat I'll do very fast. RS I'll do very fast. CVS I'll take time. Genitourinary tract also maybe I'll take some time. Endocrinology is okay. CNS is also okay. Only thing in CNS is Caesar. Caesar is the only important question which they ask. Then neuromuscular disorder, yes. Malignancy also okay. So poisoning accidents, okay. So these topics are more important, and they're actually the starting topics. So I'll finish until RS, and I'll do this, and CVS, genitourinary tract, pediatric endocrinology, CNS, neuromuscular, all of them I'll finish by 5. But yeah, the thing is, it's a really very repeated topic. You just have to repeat the same thing again. Iron deficiency anemia, we know, inadequate intake, malabsorption, increased blood loss, hookworm infestation, increased requirement, decreased iron leads to reduction in oxygen transport DNA and intracellular enzymes. So pyrrhorchinokia, anorexia, platypnea, angular stomatitis and glossitis, irritability, impaired cognition, breath holding spells, exacerbation of restless leg syndrome and Plummer-Wilson syndrome. We have microcytic hypochromic anemia, atrophic glossitis and esophageal webs. Then you have congestive cardiac failure and persistent involuntary craving for non-food substances. Okay, non-food substances, hair, feces, eyes, soil, leave it. Then one second. Diminished iron absorption is proximal small intestine problem. Proper in take of food is required. Breast milk iron is suppressed to cognic because of calcium in cow, which impairs the iron absorption. Then peripheral blood, hemoglobin will be decreased, hematocrit will be decreased, red cell volume, everything will be decreased. And then microcytic hypochromic RBC will be there, and isocyanosis will be there, poikilocytosis will be there. Serum ferritin will be decreased, serum saturation will be decreased, but total iron binding protein will be increased. Serum ferritin will be decreased, iron will be decreased. Transferritin saturation will be decreased, but total protein will be increased. Then treatment, you have oral iron therapy, which is ferrous sulfate given in between meals and given alongside with vitamin C, which helps absorption of iron. So novel iron preparation will become carboryl iron, and which has highest bioavailability. Carboryl iron, okay. Then parenteral iron therapy is iron dextran. weight times 2.3 times 15 minus HP plus 1000. Weight times 2.3 times 15 minus HB plus 1000 mg. You have to get dosage. Then response to iron treatment within 24 hours, replacement of intercellular enzyme, and decreased irritability will be there. Second day, bone marrow erythroid hyperplasia will be there. Fourth day, you'll find reticulocytosis. First month, depletion of iron source will occur. And then you have megaloblastic anemia, which is macrocytic red cell and erythroid precursor plus in clear dysmotility. So incidence varies with dactyl prosthetics and socioeconomic status. So incidence will vary depending on the dietary listing and socioeconomic status. Then there is malabsorption, which is tropical sprue, gastrectomy, intrinsic factor deficiency, which is pernicious anemia. You have botulinum lactam infestation and isolated B12 malabsorption. Then this is cobalamin deficiency. And then you have folic acid deficiency, which is maternal deficiency affecting infant, goat milk feeding. Increased requirement will be seen in prematurity and chronic hemolytic anemias. Malabsorptive states seen in tropical sprue and celiac disease. Anticonvulsant therapy, you provide phenytoin and phenobarbital. Antifolate medication therapy, you have like methotrexate and trimethoprim. All of them will lead to beta deficiency. Okay. Malabsorptive tropical sprue, gastrectomy, intrinsic factor goat milk feeding, maternal deficiency in infant. Okay. Pathogenesis, cobalamin and folic acid are involved in DNA synthesis. Deficiency leads to impaired DNA synthesis, leading to delayed nuclear maturation, leading to megaloblastic changes. Impaired DNA synthesis, delayed maturation. Deficiency leads to pancytopenia. Clinical features: you have anorexia, hypotonia, you have developmental retardation, hyperpigmentation of Meckel and terminal phalanges, fever due to neutropenia, bleeding due to thrombocytopenia. Hepatosplenomegaly will be there. So additional features: you have glossitis, beefy red to swollen tongue, and infantile tumor, which is subacute degeneration of the spinal cord. Then laboratory features: you'll find peripheral blood hematocrit HCV will be reduced, it will be more increased, reduced, and normal. So because megaloblastic increase size. Okay. Peripheral smear, you have macroovulosite lacks the central pallor. There is hypersegmented neutrophils and pancytopenia will be there. Whole Joel bodies will be there and anisopoikicytosis will be there. Biochemical findings: you have blood analysis, which is increased level of serum homocysteine, serum bilirubin, and serum LDH. So diagnostic B12 deficiency, you have homocystinuria, methyl malanoic acid excretion. Diagnostic B9 deficiency, you have homocystinuria and no methyl malanoic acid deficiency. Tests: you have Schilling's test and you have Figlo excretion test. Schilling's test is to differentiate B12 deficiency caused by pernicious anemia or malabsorption. Figlo is folic acid deficiency, which leads to it cannot be metabolized and excretion in urine will be unaltered. So okay. So Figlo is from glutamic acid. Treatment: you have specific treatment, administration of folate, B12 in response to deficiency state. Folic acid is 5 mg orally daily for 6 to 8 weeks. B12 therapy for 6 to 8 weeks is 250 mg and 500 mg you have to provide. Therapy is 10 times, 250 to 500. Okay. Concomitant administration of iron and correction of malnutrition treat the underlying cause. Okay. Hemolytic anemia is anemia resulting from increased cell destruction in presence of normal or erythropoiesis, characterized by premature cell destruction less than 120 days, elevated erythropoietin, increased hemoglobin catabolism, which is bilirubin, increased catabolysis. Then hemoglobinopathies: you have sickle cell anemia and thalassemia, enzyme deficiency, G6PD and pyruvate kinase. Membrane defects: you have hereditary spherocytosis, hereditary erythrocytosis. Deficiency: you have immune, autoimmune hemolytic anemia, and non-immune you have DIC, hypersplenism, malaria, clostridia, and chemicals and drugs also will lead to extrinsic non-immune hemolytic anemia. Clinical features: you have extravascular hemolysis occurs in macrophages of spleen, anemia, splenomegaly, and jaundice will be there. Mild decrease in haptoglobulin will be seen. Serum protein that binds to hemoglobin. Intravascular hemolysis is anemia, hemoglobinemia, severe deficiency, decrease in serum haptoglobin, jaundice, hemoglobinuria, and hemosideриnuria. Then laboratory diagnosis: you have peripheral blood, which is hemoglobin will be decreased, reticulocyte count will be increased. Peripheral smear is also there. RBC, marked increase in reticulocyte count, polychromophilia due to reticulocytosis, and nucleated red cell. Then red cell morphology provides a clue. So spirocyte, hereditary spirocyte, sickle cell signaling, and target cell will be there, acanthocyte, and cystiocyte will be there. So white blood, you have neutrophilia with shift to the left, increase in percentage of immature or young neutrophil, and presence of metamyelocyte and myelocytes. Then platelets: in acute hemolysis there is a thrombocytosis with large number of platelets. Bone marrow, you have cellular will be hypercellular, erythroid hyperplasia will be there. Erythropoiesis, anemia will be there with tissue hypoxia. There is increased production of erythropoietin and causes erythropoid hyperplasia. In hyperplasia will be there in the bone marrow. That's it. Cellular, hypercellular, erythroid hyperplasia. Bone marrow, that will be hypercellular, erythroid hyperplasia will be there. Erythropoiesis we can do, anemia with tissue hypoxia and increased production of erythropoietin. It causes erythroid hyperplasia in the bone marrow. Okay. M/E ratio, it is decreased or reversed ranging from 1:1 to 1:6. Iron overload causes are increased absorption from dietary form from duodenum, hemolysis, and repeated transfusions. All of them cause iron overload. Clinical features: you have produces homocytosis, secondary hemochromatosis, and damages to parenchyma of the organs, example heart, liver, and pancreas. There is tiredness or fatigue, there is weakness, there is weight loss and abdominal pain, and hyperpigmentation. Skin turning to bronze color. Management is iron chelating agent 1 dexamphetamine started after 10 to 15 transfusion, subcutaneously with infusion pump 5 to 6 times every week. Dose is 30 to 70 mg per day given over 8 hours. Concomitant administration of vitamin C 100 mg per day enhances excretion of iron by chelation. Hereditary spherocytosis is inherent abnormality of RBC membrane, mutation in RBC membrane proteins such as pectin and chirin and protein 4.2. So RBC membrane protein mutation will be there. Membrane loss will be there due to hemolytic stress of blood stress or blood loss. Decreased RBC surface area, which leads to formation of spirocytes, which leads to spirocytes are rigid and inflexible, leading to premature destruction and trapped and destroyed in spleen. Extravascular hemolysis. Then clinical features: you have anemia, you have splenomegaly, jaundice, pigment gallstones, aplastic crisis, and like upon separated parvovirus B9 infection. Then hemolytic crisis. Laboratory diagnosis: you have peripheral smear, bone marrow, and biochemical finding and other findings. Osmotic fragility test. Okay. Peripheral smear: spiroporocyte, polychromatophilia due to reticulocyte, and tocaleucocyte TLC will be increased, platelets will be normal, and reticulocyte will be increased. Okay, so cellularity: marked hypercellular, erythropoiesis, erythroid hyperplasia will be there, myelopoiesis will be normal, megakaryocyte will also be normal. Biochemical findings: serum bilirubin will be mildly raised, urine bilinogen will be increased, and serum haptoglobulin will be decreased. There is increase in osmotic fragility. This is hereditary spherocytosis, and this was iron overload. And this one, once again, hemolytic anemia. Myeloid versus erythroid ratio. Treatment of hereditary spherocytosis has splenectomy, preferably after 4 years of age, to prevent permanent infections. It leads to a clinical cure, prevents occurrence of gallstones, aplastic crisis, hemochromatosis, and hepatic failure. Prior to splenectomy, patient must receive a polyvalent pneumococcal vaccine. Administration of prophylactic penicillin in post-splenectomy period. Prophylactic penicillin you have to do in post-splenectomy period. Then thalassemia, you have Cooley's anemia, Mediterranean anemia. Group of inherent disorders due to abnormality of globulin production. There are a group of inherited disorders due to globulin production. Globulin characterized by decreased or absence of synthesis of either alpha or beta globulin chain in adult. Alpha or beta globulin. And HbA. Classification, you have beta thalassemia and alpha thalassemia or thalassemia syndromes. Miscellaneous thalassemia syndromes. Okay. Beta will be less, alpha will be less. Pathogenesis, you have impaired or absence of synthesis of one globulin chain. It leads to inclusion of other globulin chain inside the RBC. So RBC with single globulin chain inclusions are removed by extravascular hemolysis. Clinical features, you have moderate to severe anemia. You have untreated to or untransfused children fail to thrive and die within 4 to 5 years. Thalassemia faces, Chickman faces, prominent head, forceps, forehead, cheeks and upper jaw. Extramedullary hemopoiesis, you have hepatomegaly and marked splenomegaly. Iron overload, multiple blood transfusion may lead to iron overload. Hemocirrhosis and secondary hemochromatosis, heart, liver and pancreas. Diagnostics, you have peripheral blood, hemoglobin percentage markedly reduced, reticulocytosis will be there, and red cell indices will be decreased in MCV, MCH, MCHC. Peripheral smear, you have RBC, which is microcytic hypochromic anemia, anisocytosis, poikilocytosis, basophilic stippling, and target cells will be present. WBC will find leukocytosis with left shift, platelet will be normal. Biochemical findings, bilirubin will be increased, unconjugated type. Urine bilirubinogen will be increased. Serum aptoglobulin will be reduced. Serum iron will be increased. Serum ferritin will be increased, and transferrin will be saturation will be there and will be increased. Total iron binding capacity will be reduced. This is the only thing which will be reduced. Saturation will be increased, aptoglobulin will be decreased, urobilinogen will be increased, and bilirubin will be increased. Special tests, you have fetal hemoglobin, HbF will be increased. You have hemoglobin electrophoresis, Nestroff test, which is naked eye single tube red cell osmotic fragility test, will be positive. Radiological finding, you will find X-ray of the skull, hair on the end, crew cut appearance due to extramedullary hemopoiesis, vertical striation from winding of diploic space, and atrophy of outer table of skull. So long bones will be there, metacarpals, metatarsal, thinning of cortex, and widening of medulla due to marrow hypoplasia will be there. Treatment, you have blood transfusion again periodically at 3 to 5 weeks interval. Complications, hemocytosis, hemochromatosis, then iron chelating agent dexoferrioxamine will prevent this. Folic acid supplementation should be given, even recombinant erythropoietin should be given. Allogenic bone marrow transplantation using matched sibling is the curative treatment. Then sickle cell anemia, hemoglobinopathy characterized by quantitative defect in hemoglobin synthesis, qualitative defect in hemoglobin synthesis. It is defective or called sickle hemoglobin. Missense point mutation, glutamic acid by valine in 6th position of beta chain, and it alters solubility and stability of this thing. Glutamine and valine in 6th position. So low oxygen tension or deoxygenation, HbS molecule undergo agglutination and polymerization. Agglutinated molecules form long needle-like fibers known as tactodes within the RBC, and tactodes will distort RBC shape. RBC become elongated and assume a shape like sickle, and it predisposes to stasis and vascular occlusion. Clinical feature, in first 6 months of life has a protective role, reduces agglutination of HbS. Symptoms appear after 6 months as HbF will decrease. Okay, so sickling crisis, you'll find veno-occlusive crisis, blockage of microcirculation by sickle cell, hypoxic injury and infection will be there. Bone, you'll find hand foot disease syndrome, ectocystitis of the bone hand and feet. Lung, you will have acute chest syndrome, which is very dangerous. One complication, splenic recurrent splenic infection, which may eventually lead to aortosplenomegaly. Sequestration crisis, sudden trapping of blood in a spleen or liver leads to rapid congestion of organ, leading to drop in hematocrit, leading to hypovolemic shock. Then there is increased susceptibility to acute infection with encapsulated organism. So causes will be hypofunction of the spleen due to congestion of and poor blood flow. You have aortosplenomegaly and you have defects in alternative complementary pathway. Pneumonia will be there due to pneumoconiasis, meningitis due to pneumococcus, osteomyelitis due to salmonella, and septicemia, meningitis, most common cause of death in children. Then laboratory findings, you have peripheral blood, you have to do examination, peripheral smear, serum findings, and diagnostic confirmation tests. Peripheral blood, you have hemoglobin will be decreased, hematocrit will be decreased, ESR will be decreased, and reticulocyte count will be increased. Peripheral smear, you have anisopoikilocytosis, sickle cell will appear as a long curved cell with pointed ends, target cells will be seen, and polychromophilia will be there due to reticulocytosis. Okay. Then WBC, mild increase with shift to left, and platelets will be mild increase. Serum bilirubin, you'll find increased and predisposes to pigment gallstones. Iron status, you have raised serum iron, raised ferritin, and transferritin saturation. Serum heptaglobulinemia will be reduced. Urinobilinogen will be increased. Diagnostic and confirmatory test, you have hemoglobin electrophoresis, estimation of HbF, HPLC, high performance liquid chromatography. Prevention, you have prenatal diagnosis, so fetal DNA by amniocentesis or chorionic villi biopsy to detect point mutation. Treatment, you have pneumococcal vaccination and penicillin prophylaxis, vigorous treatment of infection. Analgesics therapy for pain cases, blood transfusion therapy, and bone marrow transplantation. Blood transfusion therapy, bone marrow transplantation. Approach, and then you have history and physical examination, whether defect is congenital or acquired, coagulative or bleeding disorder. Characteristics, you have size, severity, duration, age of onset, spontaneous or precipitated by some factor, and drug history. Physical examination will show petechiae, ecchymosis, hematomas, hemarthrosis, and mucosal bleeding. Provisional impression should be formed based on history and examination, such as development of petechiae, ecchymosis spontaneously leading to bleeding disorder, which is purpura, prolonged bleeding from umbilicus in neonate, points to congenital type of plasma clotting factor disorders. Positive family history will lead to points to existence of plasma coagulation disorder. So deep bleeding into the joints will have suggest disorder of coagulation system, and mucosal bleeding, which is epistaxis, hematuria, menorrhagia, GI bleeding. Small and multiple petechiae will be there in skin, which point to purpura. Investigations, you have CBC, TLC, and to exclude the sepsis, blood smear to exclude DIC, and prothrombin time taken following. Normal is 11 to 15, and prolonged will suggest factors deficiency 2, 5, 7, 10. Activated partial thromboplastin time is time needed for clotting of plasma. It has been activated on an inert activator such as ground-glass ellagic acid or catalin on addition of calcium of platelet. Calcium. Okay, calcium of platelets. Fine. Normal is 25 to 40 seconds. Prolonged suggests deficiency of factors 8, 9, 11, 12. Both prothrombin and APTT thromboplastin time are prolonged. Consider vitamin K deficiency, advanced liver diseases, congenital effect of factors 5 and 10. Platelet count, you have less than 20,000 centimeter per mm, causes considerable bleeding. Bleeding time, you have normally it is 4 to 8 minutes. So high bleeding with reduced platelet count is idiopathic thrombocytopenic purpura, ITP. Purpura secondary to bone marrow is aplasia or leukemia. High bleeding time in presence of normal platelet count points to anaplastic purpura, anaphylactoid purpura, platelet dysfunction. Thrombin time is time needed for plasma to clot after addition of bovine or human thromboplastin. Thrombin. Normally it is 15 to 20 seconds, prolonged in hyperfibrinogenemia, dysfibrinogenemia, and heparin contamination. D-dimer assay is level normal is less than 0.5 mg per ml, raised in DIC and pulmonary embolism. Then APT test is employed to exclude maternal bleeding neonate, and other tests you have euglobulin clot lysine time ECLT and assay for plasminogen activators and inhibitors. Then immune thrombocytopenic purpura, you have increased destruction will be there by autoimmune mechanism. Idiopathic thrombocytic purpura, Wenholm disease, purpura hemorrhagica. Types you have acute immune thrombocytopenic purpura, 2 to 4 years old. Viral infection will be there. Antibodies against platelet will be found, and thrombocytopenia will occur. It presents 1 to 3 weeks after viral, which is measles, rubella, and Epstein-Barr viral infection. Destruction is by antiplatelet antibodies. Platelet count is decreased even below 10 per cubic mm. So clinical feature is sudden onset petechiae, gum bleeding, epistaxis, and mild fever. Usually resolves spontaneously within 6 months. Chronic immune thrombocytopenic purpura is persistent thrombocytopenia more than 6 to 12 months. Most commonly seen in older children more than 10 years. Pathogenesis, formation of antiplatelet antibodies directed against group 2A, 2B. Antiplatelet antibodies, most commonly of IgG type, act as opsonine and recognized by presence on mononuclear phagocytosis of reticuloendothelial system, mainly spleen, and destroyed there, resulting in thrombocytopenia. So clinical features, you have, it is more common in female, 3:1 ratio is there, skin bleeding is there, mucosal bleeding is there, menorrhagia will be there in females. Differential diagnosis, you have purpura secondary to aplastic anemia, leukemia, lymphomas, and AIDS. So diagnosis, you have peripheral smear, thrombocytopenia with increased platelet size, bone marrow, there is increase in mature megakaryocytosis, bleeding time will be prolonged, APTT will be normal, clotting time will be normal, tourniquet test will be positive, test for platelet autoantibodies will be positive, and spleen will be normal size. So immune thrombocytopenic purpura is basically what I say, destruction of platelets by autoimmune mechanism. Idiopathic thrombocytic purpura. So types, you have autoimmune acute immune thrombocytopenic purpura, which is 2 to 4 years. So viral infection, antibodies against platelet, and thrombocytopenia will occur 1 to 3 weeks after the viral infection. And 1 second, give me a second, I'll be right back. Is it a polyp or something? No. I would like speaking a little bit, just made a polyp in my mouth. Okay, sorry about that. I don't know, for some reason there's something sticking in my throat. It looks like a polyp or some shit. Viral infection is autoantibodies against platelet, thrombocytopenia. 1 to 3 weeks after viral. Destruction antiplatelet antibodies less than 10 per cubic mm. Features will be sudden onset petachy, chronic bleeding, epistasis, mild fever, resolve spontaneously within 6 months, and chronic will be present more than 6 to 12 months, most commonly in more than adult children. And formation of antiplatelet antibodies is directed against GP2A and GP2B, 3B. Most of them are IgG type and act as opsonin and are recognized by presence of mononuclear phagocytosis of reticular endothelial system, mainly spleen, and destroyed there, resulting in thrombocytopenia. So clinical features you have more commonly in female, 3:1, and the skin bleeding will be there, mucosal bleeding will be there, hemorrhage will be there in females. So differentially it could be purpura, secondary to aplastic anemia, leukemia, SLE, and lymphomas and AIDS. So diagnosis in peripheral smear, which is thrombocytopenia with increased platelet size, bone marrow will be increased in immature megakaryocytes, bleeding time will be prolonged, PT and APTT will be normal, and clotting time will be normal, tourniquet test will be positive, and test for antibody will be positive, and spleen will be normal size. Treatment you have methylprednisolone, which is 30 mg per kg per day for 3 days, IVIG, IV immunoglobulin for 1 gram per kg per day for 2 days. Intravenous anti-D can be used in Rh positive individuals. Platelet transfusion will lead to only in case of life-threatening bleeding. Plasmapheresis can be seen. Laparoscopic splenectomy can be done, which is best treatment for symptomatic children. Then hemophilia is X-linked inherent bleeding disorder commonly affecting male child. So classification, you have hemophilia A, B, and C. So A is deficiency of factor 8, anti-hemophilic factor, and B is deficiency factor 9, plasma thromboplastin component, and C is deficiency of factor 11, plasma thromboplastin and antecedent, PTA. Clinical manifestation, you have excessive bleeding, you have contusions or hematomas, epistaxis is there, bleeding after tooth extraction or tonsillectomy can be seen, and hemarthrosis, especially of knee, ankle, and elbow, leading to repeated attacks cause inflammation and degenerative changes, leading to joint becoming immobile, fixed joint. Then bleeding may occur into genitourinary tract, CNS, GIT, liver, spleen, and peritoneal or pleural cavity. So there is extensive bleeding. Okay. And complications, you have deforming arthritis and contractures and anemia. Investigations, you have to do blood tests, radiological investigations are there, and antenatal diagnosis is possible. So blood tests, the bleeding time will be normal, clotting time will be prolonged, and platelet count will be normal, prothrombin time will be normal, activated partial thromboplastin time APTT will be increased. Fibrinogen assay will be normal, and FDP will be negative. Factor 8 assay you have essential for diagnosis and to assess levels and severity of disease. Radiology is done in case of hemarthrosis, synovial thickening, demineralization and erosion, and contracture will be there. Increased vasculature of joint space will be there. Premature appearance of ossification centers may occur. Then complete destruction of articular surface and formation of juxta-articular cysts is noticed. Antenatal diagnosis is possible at 18 to 20 weeks of gestation, requiring fetal blood and demonstrating lower procoagulant component and PCR technique and oligonucleotide parameters. Primers you can do. And hemophilia. So here there is pure decrease, so you can say look, thrombocytopenia, decreased in thrombocytes, okay, and increase in platelet size, okay. Bone marrow increase in immature megakaryocyte because there is less platelets. Bleeding time will be increased. PT and APTT will be normal. Prothrombin time and null will be normal. Clotting time also will be normal. Tourniquet test will be positive. Okay. Bleeding time will be increased, normal and normal, tourniquet will be positive, antibody will be, spleen will be normal. Okay, here the bleeding time will be normal, but clotting time will be increased, the completely opposite of idiopathic thrombophilic thrombophilia. Platelet count will be normal and prothrombin time will be normal. APTT will be increased, only APTT will be increased. Fibrinogen assay will be normal. Factor 5-8 assay will be essential for diagnosing, and severity also it is required. Antenatal also you can perform. Radiologically, synovial thickening, demineralization, vascularization, increased vascularization, and premature appearance of fasciculation center and complete destruction of articular surface. See, treatment is symptomatic measures. You have cleansing, open injury, rest, ice you can do, local cold to achieve vasoconstriction, compression, and elevation of water, rise. Local application of thrombin powder or foam. Okay. Specific measures: you have severe bleeding, the whole threshold blood you have to give, mild to moderate frozen plasma, and factor 8 concentrate or recombinant factor 8. Minor bleeding, you provide desmopressin and danazole and antifibrinolytic agents. You have tranexamic acid, epsilon anticaproic acid, disseminated intravascular coagulation, chest consumption coagulopathy, thrombohemorrhagic disorder to characterized by excessive activation of coagulation leading to formation of thrombi in microvasculature. Etiologically, you have acute DIC, chronic DIC, and neonatal DIC. Infections, trauma, crush injury, burns, major surgery, miscellaneous, snake bite, acute ferment hepatic failure, hemolytic uremic syndrome, mismatched blood transfusion, acute polymyositic leukemia. Malignancies will be there: leukemia, disseminated neuroblastoma, cardiovascular disorder, shock, cyanotic congenital heart disease, hemolytic anemias, thalassemia, sickle cell disease, collagen vascular disease, SLE, Hohenschwann purpura, and polyarthritis nodosa. Neonatal, you will have asphyxia, hypothermia, and shock. Pathogenesis, there is two mechanisms. There is release of tissue factor or thromboplastic substance into the circulation Widespread endothelial cell injury will be there. Clinical features, you have hemorrhagic diathesis or bleeding due to consumption of platelet, consumption of clotting factors, and activation of fibrinolytic system. There is ecchymosis, decay, and bleeding from mucous membrane or at site of any puncture. You have microvascular thrombi and tissue hypoxia, infection of organ leading to multi-organ failure. Laboratory findings, you'll find screening assess APTT, it is increased as a result of consumption and inhibition of function of clotting function. Prothrombin time will also be increased. Thrombin time will be increased because of decreased fibrinogen. Fibrinogen will be decreased. Bleeding time will be increased due to decreased platelet count. Platelet count is decreased. Platelet count will be decreased due to utilization in microthrombi and peripheral smear. Microangiopathic hemolytic anemia with cystocytes. APTT will be increased as a result of consumption. Prothrombin time will be increased, thrombin time will be increased, fibrinogen will be decreased, bleeding time will be increased, platelet count will be decreased, and peripheral microangiopathic hemolytic anemia with histiocytes. Confirmatory tests, you have fibrin degeneration or split products, FTP. So secondary fibrinolysis results in generation of FTPs, which dimer test also can be done, which is specific for diagnosing DIC. Treatment is fresh blood transfusion, thrombocytopenia, cryoprecipitates for hypofibrinogenemia, fresh frozen plasma to replace other coagulation factors, exchange transfusion, double volume to eliminate toxins circulating FTPs and activate procoagulants. Anticoagulant therapy is treatment of choice is hemoglobin, heparin. Then aplastic anemia, chronic pulmonary hematopoietic stem cell disorder characterized by pancytopenia, anemia, neutropenia, and thrombocytopenia with marked hypocellular bone marrow. Etiologically, it can be idiopathic. Chemical agents, you have cytotoxic drugs, and chelating agents and antimetabolites, benzene, chloramphenicol, penicillamine, and carbazepine. Physical agents have whole body irritants and viral infection, hepatitis B, Epstein-Barr virus, cytomegalovirus, HIV. Inherited, you have Fabroni's anemia and telomerase deficiency. Pathogenesis is direct damage to hematopoietic stem cells and progenitor cell. Immune mediated destruction, primary stem cell abnormality is inherited defect in stem cells. Clinical features, you have progressive weakness, pallor and dyspnea due to anemia, frequent infections due to neutropenia, decay, bruises, and ecchymosis due to thrombocytopenia. Laboratory finding, hemoglobin will be decreased, paxil volume will be decreased, reticulocyte count will be markedly decreased, peripheral smear you will find pancytopenia, and bone marrow you will find marked hypocellularity. Treatment, you have bone marrow transplantation, intensive immunotherapy with anti-lymphocyte or anti-thrombocyte globulin cyclosporins. Then we talk about red cell indices, MCV, MCH, MCHC, and random red cell distribution widths. Okay, so MCV indicative of average volume, it is femtoliters, 80 to 100 femtoliters. Then MCH is hemoglobin per RBC, picograms, normal range is 27 to 32 picograms. Mean corpuscular hemoglobin concentration is average concentration of hemoglobin in RBC taking volume into account, expressed as gram per deciliter, better indicator for hypochromasia than MCH. Gram per deciliter, it is picograms. Femtoliters, picograms. And 27 to 32, 80 to 100, 27 to 32, here it is like 100 by 32 maybe, something like that. You can remember it, but technically you can, it's just easier to remember 31 35. So 92 to 32, so 31 to 35. Red cell distribution width is quantitative measure of anisocytosis. Normal red cell distribution is 11 to 14%. Raised red cell distribution width indicates that red cells are heterogeneous in size and shape. Then we move on to pediatrics, respiratory system. So respiratory system, 1 second. It's an inflammatory process involving lung parenchyma due to microorganism peritonitis. Pneumonitis is pneumonia due to non-infective etiology. Community acquired pneumonia is acquired outside hospital environment. Nosocomial or acquired hospital acquired pneumonia is pneumonia acquired within 48 hours after hospitalization. Recurrent pneumonia is 2 episodes in 1 year or 3 episodes at any time. Classification, etiological classification, you have bacterial, which may be streptococcal, staphylococcus, H. influenzae, Klebsiella, M. tuberculosis, chlamydia. Mycoplasma pneumonia is most common in more than 5 years of age. Rickettsial, you have typhus, Rocky Mountain, or spotty fever. Influenza and measles also can be there. Respiratory syncytial virus is overall most common cause of viral pneumonia, and chickenpox, fungal also may be there. Fungal, you have coccidiomycosis, histoplasmosis, blastomycosis, pneumocystis carini. Then protozoal, you have toxoplasma gondii and entamoeba histolytica. Based on chronicity, you have acute, chronic, which is recurrent and persistent. Predisposing factors, you have immunodeficiency, protein energy malnutrition, and HIV. Congenital respiratory malformation, you have tracheoesophageal fistula, gastroesophageal reflux disease. Good. Then congenital heart disease, you have ventricular circle defect. Defective clearance of airway secretion is there in 65 versus. Chronic pulmonary disease, you have tuberculosis, bronchiectasis, asthma. So anatomical classification, you have bronchopneumonia, lobar pneumonia, pneumonitis. Based on acquisition, it can be congenital, community acquired, or hospital acquired. Bronchopneumonia, there is patchy involvement of the lungs. Lobar pneumonia, one or more lumps are involved, and pneumonitis, alveoli or interstitial tissue will be affected. There are various types of pneumonia they have been explaining. Okay, let's see. So pneumococcal pneumonia is pneumonia, droplet infection with winter months, overcrowding, reduced shower space, alveoli inflammation, exudates. There is scattered areas of consolidation, headache, chills and cough, thick respiratory sputum, grunting, chest indrawing, feeding difficulty, and cyanosis will be there. Impaired percussive note is heard, and bronchial breathing is common. Then bronchophony will be there, whispering, phylogyny, and meningismus will also be there. Diagnosis, you do X-ray, you will find lobar consolidation, grand staining and culture of sputum, and demonstration of antigen in blood and urine. You can do. Treatment is with penicillin G. Then staphylococcus pneumonia, you have infancy and childhood. Complication of influenza, measles, cystic fibrosis, bronchoalveolar destruction will be seen. Multiple micro abscess formation will be there. There is formation of nematocells. Complications, you have pericarditis, empyema, pneumothorax. Treatment, you have hospitalization, IV fluids you provide, antipyretics, and hydration you have to do. Penicillin G1, cloxicillin, ceftriaxone, and vancomycin, linezolid can be done. Viral pneumonia is less than 6 months of age. Pro-influenza, para-influenza, influenza, and adenovirus, all of them are viral pneumonia. Perihilar and peribronchial infiltrations can be seen. Streptococcal pneumonia is group A beta hemolytic disorder. Respiratory distress in newborn, and virulent empyema is a complication. Hemophilus pneumonia, you have 3 months to 3 years. You can occur bacterial infection in nasopharynx, dyspnea, grunting, and retractions can be seen. Presentation mimics acute bronchiolitis, and complications, you have bacteremia, pericarditis, empyema, meningitis, polyarthritis. Treatment, you have parenteral ampicillin and ceftriaxone. Atypical pneumonia is mycoplasma, chlamydia, and legionella species. Droplet will be there, overcrowding in the winter. Then 12 to 14 days of incubation period is there. Headaches, fever, malaise, sore throat will be there. Cough and myalgia. Cough is dry at first, later it becomes mecorium aspirate expectoration. Macrolide antibodies is erythromycin, azithromycin, and tetracycline. So there is high fever, chills, cough, respiratory distress, diminished chest volume, increased vocal resonance, dullness on percussion, diminished breath sound, bronchial breathing, crepitations, and no mediastinal shifting. Tachypnea is most common side. WHO definition: less than 2 months is more. Less than 2 months if it is more than 60 per minute. 2 to 12 months it is more than 50 per minute. 1 to 5 years is more than 40 per minute, and more than 5 years is more than 20 per minute. Complications: you have pleural effusion, emphysema, collapse, pneumatocyst, lung abscess, bronchiectasis, submucous emphysema, and metastatic spread. You have meningitis and osteomyelitis. Diagnosis: you have chest X-ray, PA view, consolidation, pleural effusion, pneumothorax, and pneumatocyst, small inflated abscess. Management is in children more than 2 months, oxygen inhalation, IV fluids, amoxicillin. Okay, monitor respiratory, chest indrawing, oxygen saturation, assessment after 48 hours. Improvement: feeding well, no chest drawing, indrawing, specific pressure of oxygen more than 92%. We provide amoxicillin for 7 to 10 days. No improvement: third generation cephalosporin, cefotaxime, and gentamicin for 14 days. Acute respiratory infection is classified into 3 categories: very severe, and no pneumonia. Very severe is stopped feeding well, difficulty to wake, convulsions, stridor, and severe malnutrition. ICU admission and IV penicillin aspirin for at least 5 days. Severe pneumonia is severe chest indrawing and tachypnea will be there. Well feeding and no hypoxia. Treatment on ambulatory basis: oral amoxicillin 40 mg per kg twice daily, 5 days. No pneumonia is upper respiratory tract infection, that's it. There is no chest indrawing and no tachypnea. Color coding: pink is very severe, refer to hospital, and yellow is pneumonia, antibiotics and home care. Green is no pneumonia. So amoxicillin 7 to 10 days, cephalosporin, cefotaxime, gentamicin. Amoxicillin, then cefotax. Acute epiglottitis is rapid progressive cellulitis of epiglottis. Etiologically, it can be H. influenza, GABH, and Staphylococcus. Clinical features: acute onset fever, respiratory stridor, inability to lie supine. Swollen epiglottis closes the airway. Tripod position: the patient will sit leaning hand against the bed, and head held in sniffing position. Adenophagia will be there, and drooling of saliva can be there. So you can do indirect laryngoscopy, congested swollen epiglottis, and raised beam appearance will be there. X-ray, you will find thumb sign. Swollen epiglottis appears like a thumb. Management: antibiotics therapy, third generation cephalosporin, 100 mg per kg per day. Fluid submission for adequate hydration through IV. Then steroids, you have decrease the inflammation and reduce the edema. In case of respiratory distress, you do intubation and tracheostomy. Then you have pleural effusion, which is collection of serous fluid in empyema. It's purulent fluid in pleural fluid. So etiologically, you have tuberculosis, pneumonia, congestive cardiac failure, constructive pericarditis, hypoproteinemic state like nephrotic syndrome, kwashiorkor, protein losing enteropathy, and hepatic failure. Thoracic lymphoreticular malignancy can also be there. Clinical features, you have high fever and cough, chest pain on affected side which versus on deep breathing and coughing, reflex abdominal pain and breathlessness, and physical examination you'll find decreased chest movement, mediastinal shift to the opposite side, fullness of intercostal space, pleural rub will be there, decreased vocal phrenitis and resonance, toneadal percussive note. Above the effusion level, you have agophony, which is hyperresonance due to compensatory emphysema. LS curve refers to upper limit of dullness to percussion caused by pleural effusion. Characteristic slope of a curved line with highest pointed midline in mid-axillary line. So diagnosis, you have chest X-ray, which is uniform opacity, mediastinal shift to the opposite side. Ultrasonography can be there, and pleural tap also can be there. Transudate and versus exudate. That is an important question they ask. It's always. Give me a second actually. lot of the topics, there's a lot of overlap. As such, you can just write on your own a lot of times. So there's a problem which is happening right now. I'm going to stop it for a second actually.